Hello guys, today I'm going to cover one more new topic from ENT, that is from the nose series, actually Rhino series. That is the first topic from the nose series, which is allergic rhinitis. It's a very small topic and we'll cover it like within next like 10 minutes and it will be completely done. So I hope you stay coordinated. Let's begin. Rhinitis is basically also called as a common cold, and allergic rhinitis means it's basically an immunoglobulin E mediated immunological response of the nasal mucosa to the airborne allergens. So basically, it's an immunological response of nasal mucosa. The clinical features include watery discharge, nasal obstruction. Clinical features may sneezing and itching in nose, and also clinical feature may also include association with itching in eyes, palate and pharynx. It is through two agents we can see, like seasonal allergic rhinitis and perennial allergic rhinitis. So what does it mean by seasonal allergic rhinitis? Means basically symptoms appear in and around a particular season when the pollens of a particular plant to which the patient is sensitive are present in the air, and perennial means symptoms are present throughout the year. Talking about etiology, inhalant allergens, basically they can be also seasonal or perennial. Pollens from trees, grasses and weeds. Perennial allergens are present throughout the year regardless of the season. Example: molds, dust mites, insect parts and animal danders. That is, this dust it include dust mite, it include insect parts, it also include animal danders, and basically cockroaches are one of the thing. Dust mites which live on the skin scales or other debris are found in beddings, mattresses, pillow, carpets or upholstery. Genetic predisposition, basically it plays an important role. Chances of children developing allergy are about 20% to 47%, and respectively, like 20% if one parent is allergic and 47% if both parents are allergic. Now we'll talk about the pathogenesis. So what we have is that the inhaled allergen will basically produce a specific IgE antibody. This IgE antibody will have basically a region known as a Fc region. This Fc region of either mast cell or some blood basophil, it will go and attach. Then this allergen basically will attach to FAB region of the IgE antibody, and thus antigen of the allergen getting attached to FAB region of IgE antibody and IgE antibody getting attached to Fc region of blood basophil or the mast cells. So yes, the next one will be basically the reaction will produce basically degranulation of mast cells with the release of several chemical mediators. So what are those chemical mediators? First is that chemical mediators which can be already pre-existing ones or the new chemical mediators. Those are like preformed mediators mean histamine, then ECFA, that is extrinsic chemotactic factor A, NCFA, heparin and others. And here in newly synthesized we have basically prostaglandins like PGD2, leukotrienes like SRSA, platelet activating factor, thromboxane A, and tumor necrosis factor alpha. So we will see one by one. First, that is histamine. This histamine is going to basically cause two function: vasodilation and bronchospasm. These two functions are going to do. Then eosinophilic chemotactic factor A, sorry for previous thing, basically it's eosinophilic chemotactic factor A, that will be for basically anaphylaxis and attract eosinophil to site of reaction. Then neutrophil chemotactic factor A attract neutrophil. Heparin basically cause phagocytosis. Then what we have is a prostaglandins, which will cause vasoactivation and bronchospasm. Again leukotrienes, same action, vasoactivation and bronchospasm. Then we have basically platelet activating factor. This platelet activating factor is going to do platelet aggregating factor, then histamine, serotonin, which is released from platelets, causes chemotaxis of neutrophils plus eosinophils. Thromboxane A2, which is actually spasmogenic. Then tumor necrosis factor alpha helps in transmigration of basically neutrophils and eosinophils and attract them to site of reaction. So one more good diagram would be like this. As you can see in this diagram, that's a specific allergen stimulus IV mediated drop in CAM to CGMP ratio, released of preformed and newly formed mediators, increased vascular permeability and vasodilation, tissue edema and nasal blockage, change in smooth muscle tone causing bronchospasm, hyperactivity of gland, increased secretion and rhinorrhea. Clinical feature include basically usual age of onset being about 12 to 16 years of age. It may start in infant as young as about 6 months or in older people. Cardinal symptom of seasonal nasal allergy being paroxysmal sneezing, 10 to 20 sneezes at a time, nasal obstruction, watery nasal discharge and nasal itching. Itching may also involve eye, palate and pharynx. Bronchospasm of variable severity and duration is observed. Talking about symptoms of perennial allergy, those being hearing impairment due to Eustachian tube blockage and fluid in middle ear, frequent colds, persistently stuffy nose, loss of smell sensitive to mucosal edema, post-nasal drip being commonly observed, and chronic cough as a result of a post-nasal drip also. Signs include nasal, in which we have transverse nasal crease, pale plus edematous. This talking about this transverse nasal crease now, it's basically on our nose. There is basically a black line across the midline of the dorsum of nose. Like if this is the dorsum of nose, across the midline of the dorsum of the nose there is a black line, that is called as a transverse nasal crease, and that is because of constant upward rubbing of nose stimulating a salute, that is allergic salute. And next up being pale plus edematous nasal mucosa, which may appear bluish, swollen, turbinates, thin watery or mucoid discharge which is always present. Always means almost usually. Talking about ocular signs being lid edema, congestion, conjunctival cobblestone appearance, dark circles under eye. Talking about otologic signs being retracted tympanic membrane or serous otitis media due to Eustachian tube blockage. As we have seen here, Eustachian tube blockage. Now talking about pharyngeal signs and laryngeal signs. Pharyngeal signs basically are like granular pharyngitis due to hyperplasia of submucosal lymphoid tissue. We have to also understand it is almost similar, which is seen as a pharyngitis due to adenoid hyperplasia. And laryngeal signs is basically hoarseness and edema of vocal cords. Differential diagnosis or diagnosis dependent on duration and symptoms of the disease. So what is ARIA? ARIA is basically new allergic rhinitis and its impact on asthma. So what is this asthma? Basically duration of disease, intermittent and persistent, two in which we have classified. Intermittent being less than 4 days a week or 4 weeks, more than 4 days a week or 4 weeks. Severity of disease dependency, that is mild severity, sleep disturbance, impairment of leisure activity or sport, impairment of school or work and troublesome symptom. If none of this is present, it is considered as of a mild severity of disease. Then more moderate or severe severity is considered if any one of these symptom is present, or even more than one of these symptom is present. Talking about investigation, total leukocyte count and differential leukocyte count is considered, but it's actually inconsistent finding of peripheral eosinophilia. Then nasal smear is taken. It shows basically NARES, which means non-allergic rhinitis with eosinophilia syndrome. Then we have skin tests. In the skin test, basically what we have is a skin prick test. Skin prick test means what is done intradermally on the forearm. The allergen is injected, and within like 10 to 15 minutes, if it is a positive test, will observe a central veal reaction and surrounding zone of erythema. This is known as a veal and flare reaction. Also other tests in this skin dermal allergen test will be basically scratch and intradermal tests are also done. Then talking about specific immunoglobulin measurement, in vitro test to find specific allergen, good correlation between the skin test and specific IgE measurement. However, both false positive and false negative result can occur. It is recommended to correlate the two tests with clinical symptom. Also, we have one more, which is radio allergosorbent test known as a RAST. What is this? It's an in vitro test. It measures a specific immunoglobulin E, that is specific immunoglobulin E antibody concentration in patient serum. Talking about nasal provocation test, how is it exactly carried out? So talking about nasal provocation test, it's a crude method to challenge the nasal mucosa. That is what happens over here is basically by a small amount of allergen which is placed at the end of a toothpick and asking the patient to sniff into each nostril and to observe if the allergic symptoms are reproduced. More sophisticated technologies are available now, so basically this is not much used. Next is a complication. We talk about complications include recurrent sinusitis, formation of nasal polyp 2%, serious otitis media, orthodontic problems, bronchial asthma. That is almost 20 to 30% of patients with rhinitis have bronchial asthma. Now we will talk about the treatment. Treatment may first what we have is basically the avoidance of allergen. If a single allergen is responsible for it, then this is the best treatment we can give for allergic rhinitis. Now talking about treatment with drugs. First drug we have is antihistaminics. So let's first see how antihistaminics helps. So basically antihistaminics control, first is rhinorrhea. They control rhinorrhea, sneezing, and they also control the nasal itch. So all antihistaminics have a side effect, that is side effect being the drowsiness in this condition, and also some more or other, and the dose and type of antihistaminic has to be individualized. If one antihistaminic is not effective, maybe other different class antihistaminic can be tried. Second one was a sympathomimetic drug. Sympathomimetic drug can be both oral as well as topical in nature. So alpha adrenergic drug will basically constrict the blood vessels, and once the blood vessels are constricted, as a result it will reduce the nasal congestion, as you can see over here. And once nasal congestion reduced, the edema will also get reduced, and at the same time we can see what happen is they will cause a CNS stimulation, and this CNS stimulation will basically often given in combination with the antihistaminics to counteract drowsiness. So drowsiness caused in this case can be counteracted by giving the sympathomimetics. That next one being the corticosteroid. So third one being the corticosteroid. What is the use of corticosteroids? So basically oral corticosteroids are very effective in controlling the symptoms of allergic rhinitis, but the use should be limited because of a several systemic side effects as it has. Next what we have is fourth one being the sodium chromoglycate. So what does this mean by sodium chromoglycate? Basically it stabilizes the mast cell and it prevents them from degranulation despite the formation of the IgE antigen complex. So mast cell degranulation can be stopped by complex used as a 2% solution of nasal drops. 2% solution of nasal drops it can be used as, and also it's important to use it as a spray or aerosol powder. It is useful both in seasonal plus perennial allergic condition. Next what we have is the anticholinergics. Anticholinergics, fifth one. In anticholinergics, basically they will block the rhinorrhea and both the allergic and non-allergic rhinitis, and also it's important both allergic rhinitis they will block plus non-allergic rhinitis, both of them will be blocked by them. And it's very important that ipratropium bromide has been used as nasal spray to control the rhinorrhea. Next is a leukotriene receptor antagonist. Okay, leukotriene receptor antagonist, they include montelukast, pranulikast and zafirlukast. So it's very important they will block the cystinyl leukotriene type receptor, well tolerated and side effect. Next, seventh one being basically the anti-immunoglobulin E. It reduces the immunoglobulin E level and has basically anti-inflammatory action. And what we have is basically omalizumab as a drug. So this omalizumab is such a drug which is indicated in children about 12 years of age who have moderate to severe asthma. They are not approved for all types of rhinitis. Now guys, let's talk about immune therapy, that is step care approach. What happens in exactly this? Understand immune therapy, also called as a hyposensitization. Here what happens is there are intolerable side effect produces drugs fail to control symptoms at the time this is used. What happens? Allergen is given in gradually increasing dose till it reaches the maintenance dose, and is basically an uninterrupted treatment for 3 years, shows no clinical improvement, and its indication is there. It raises a specific titer of IgG antibody. So subcutaneous immunotherapy is often used, but now sublingual and nasal routes are also used, and the dosage given them is almost 20 to 200 times greater than the subcute route when it is given by basically sublingual and nasal route. Now let's discuss the step care approach. Now talking about the step care approach which is recommended by ARIA for allergic rhinitis treatment. First, oral antihistaminics. Oral antihistaminics or intranasal cromolyn sodium is recommended for basically mild intermittent disease. And second one, for allergic symptom of moderate severity or persistent disease, intranasal corticosteroids can be used for monotherapy. Then third is for severe symptom, combination therapy with non-sedating antihistaminics and intranasal steroid is used. Then basically fourth, for severe and persistent symptom in spite of about treatment, a short course of oral steroids and immunotherapy is also recommended. Then fifth, if nasal obstruction persists for a short course, then intranasal decongestants can be used. Oral decongestants can be combined with antihistaminics. And the last one, 6, is basically non-allergic rhinitis can coexist with allergic rhinitis. Therefore, we should avoid the allergen and irritant in all forms of disease. Non-specific stimuli may produce allergic rhinitis like symptom due to basically hyperreactivity of nasal mucosa. So these were the stepwise approach. Yes guys, what I want to say is thank you so much for your patient hearing, because this topic was actually very small but it's clinically extremely significant, and I find very easy to explain it actually. Stay tuned for more videos from the rhino part of Otorhinolaryngology series. Thank you so much.